Saumil's talk. I am doing this talk for Dr. Saumil Seth because he's not in the country, but he's been kind enough to send his presentation. Saumil is a very accomplished surgeon, and he does all these very dangerous, deadly cases with a lot of ease and elan. Let's go over and see what he does. So the first case is a case of a central retinal artery occlusion which he's tackled. There's a voiceover so you can hear him say what he has to say. Volume कर देना.
A 75-year-old female with a known history of coronary artery disease
Can you hear?
presented with central retinal artery occlusion of 18 hours duration. A cigar-shaped embolus extending along superior and inferior arterioles was noted in the optic disc area. From its physical appearance, it appeared to be a cholesterol plaque. Began by performing a 23-gauge vascular vitrectomy with
1
PVD
minute.
induction.
Can't hear ना.
Internal limiting
आप connect कर दो. Okay, I'm going to start this.
techniques to relieve a central retinal artery occlusion, especially when operated upon by vitrectomy less than 24 hours. A 75-year-old female with a known history of coronary artery disease presented with central retinal artery occlusion of 18 hours duration. A cigar-shaped embolus extending along superior and inferior arterioles was noted in the optic disc area. From its physical appearance, it appeared to be a cholesterol plaque. Began by performing a 23-gauge pars plana vitrectomy with PVD induction. Internal limiting membrane peeling was performed as an added measure to improve foveal oxygenation, at least theoretically, as some reports mention, in case we were not to succeed in our embolus dislodgement. ILM comes piecemeal and care needs to be taken to avoid trauma to boggy nerve fiber layer. ILM is peeled in the peripapillary area to aid physical contact maneuvers with the artery. A cigar-shaped embolus extending along superior and inferior arterioles was noted in the optic disc area. This maneuver, creating low pressure in the vitreous cavity, may enhance arterial pressure gradient, forcing the embolus out. So we clamp the infusion port and give active suction to aid the arterial pressure to push the embolus forward. Hypotony endpoint being disc elevation and development of peripheral choroidals. Maneuver 2, surgical deangulation of the arteriolar bend for the emboli to get released along a straight path. We pinch and pull the adventitial sheath of the vessel as well as straighten it out. This teasing can either dislodge or fragment an embolus. As we see the embolus migrating distally, complete filling of the vessels is taking place behind the embolus, restoring retinal circulation on the spot. Those who missed it, let's do it again. We would like to describe this process as a most extreme form of digital massage of the CRO that can be possible as it is performed directly on the vessel. Next attempt at arteriolar teasing releases embolus fragments along two superior arterioles. For those who missed it, let's do it yet again. Maneuver 3, milking and pushing the embolus along the vessel. While dislodging the inferior embolus does migrate but stop short at the fork. This should be okay as macular circulation has already been established and we need no further maneuvering. circulation, as we see, is finally restored, and
Beautiful case. Vision recovered to 618, which is good. His next case is he's one person who really thinks out of the box. So this is about a subfoveal plaque.
our case is a 65
Of hard exudates.
year-old diabetic and hypertensive female with best corrected vision of finger counting 2 to 3 meters and a history of multiple intravitreal injections and steroid implants in the past, presenting with a subfoveal hard exudate plaque in an otherwise dry macula. Her OCT shows the plaque to be located intraretinally or specifically within the outer plexiform layer of the fovea rather than subretinally, which is between the photoreceptors and the pigment epithelium. Conventional surgical approach involves poking the retina in the paramacular area with a 41 gauge needle, inducing a localized iatrogenic foveolar retinal detachment with saline injection, and then going on to aspirate the hard exudate plaque in the outer plexiform layer. In this process, one passes through all the foveolar retinal layers, causing potential damage not only to the pigment epithelium but also the neural elements, namely the photoreceptor outer segments and nuclei. This collateral damage may result in poor visual outcomes. My surgical approach involves aspirating the hard exudate plaque from the top of the fovea after poking through just its inner lamella, creating a lamellar or partial thickness iatrogenic macular hole. Thus, apparently poking where it hurts the most in the eye could actually be the place where it will damage the least, as my technique incurs potential harm only to the Mullerian cell cap and no neural elements, as no neural layers exist beyond the outer plexiform layer at the fovea. As seen in OCT and histology, we are using the unique foveolar anatomy to our advantage, as by poking from the top involves much lesser neural tissue interference than that incurred when approaching from the bottom, leaving us with a macular hole lamellar in nature, which post internal limiting membrane peel will close like any other macular hole. As in any vitrectomy surgery, the first step is PVD induction, during which we realized it is a proliferative retinopathy and bleeders were pressed with vitrector for hemostasis. After staining with brilliant blue dye, the ILM was peeled in order to close the iatrogenic macular hole that will be subsequently induced. As is typical in diabetics, ILM is tightly adherent and was peeled piecemeal. Alternatively, ILM flap could have been made for better closure of the macular hole. Light separation at the top of the fovea will possibly hurt only the Mullerian connective tissue and not the neural elements. Hard exudate plaque was then aspirated, leaving an iatrogenic lamellar macular hole that will close like any other hole. Laser with air fluid exchange was performed, followed by gas injection and prone posturing. Post-operatively, good visual recovery was noted with type 1 hole closure.
After that second case is his third case, which is a case of Coates disease. There's no voiceover in this, so I'm going to fill in for him. He goes ahead with a cataract removal first because this is a very highly elevated exudative detachment that you see. And after completing the cataract, he puts in a lens implant. In the bag, dials it into place. Then he goes ahead to fix AC maintainer, and at the height of maximum fluid he goes in and aspirates the fluid. You can see the yellow fluid coming into the syringe, and visualization is carried out where he sees the fluid generally reduce and the retina go back. What normally happens in these cases, a lot of hard exudates also escape along with the exudative fluid. So there's generally a reduction in the number of hard exudates which is generally there. And with this vitrectomy, he just goes ahead and the areas which have the telangiectatic vessels, he's doing laser for those areas. And then a fluid gas exchange, and he settles the retina. Looks near normal now, except this part has to shrink off. Thank you.